Hey everyone, today we are diving deep into a super important tool in respiratory support, non-invasive ventilation, or NIV. We're going to treat this like a complete clinical study guide, something that's going to help you in your practice and of course on your exams. So let's get right into it.
So here's our game plan. We'll start with the absolute basics. What even is NIV? Then we'll get into the big one, CPAP versus BiPAP. After that, we'll tackle the settings, figure out who should and shouldn't get NIV, and then, my favorite part, we'll hit some key NCLEX tips and wrap it all up with a real-world case scenario. Okay, first things first. We have to build a solid foundation. So let's define exactly what we're talking about when we say non-invasive ventilation. At its heart, non-invasive ventilation is pretty much exactly what it sounds like. You're giving a patient all the help of a ventilator, but you're doing it through a mask instead of an invasive tube. It's how we provide that critical breathing support while trying to avoid the risks that come with intubation. And believe me, for the right patient, it's an absolute game changer. Now, NIV isn't just one single thing. It's really a category with a couple of major players. You've got high-flow nasal cannula, which pushes warm, humidified oxygen at really high rates. And then you have non-invasive positive pressure ventilation, or NIPPV. For our study guide today, we're really going to zoom in on NIPPV because that's the home of the two big workhorses we all know, CPAP and BiPAP. So this leads us to the question that trips up so many people. What is the real difference between CPAP and BiPAP? Honestly, it all comes down to a really simple idea. Are we using one pressure or are we using two? And this slide lays it out perfectly. With CPAP, think of it like a steady, continuous breeze of air. You get one single, constant pressure, whether you're breathing in or you're breathing out. BiPAP, on the other hand, is more dynamic. It's bilevel, which is just a fancy way of saying it gives you two levels of pressure. You get a bigger push of air when you inhale, and then it backs off to a lower pressure when you exhale, which makes it a lot more comfortable.
And that one simple difference, one pressure versus two, leads to totally different goals. CPAP, with its one steady pressure, is fantastic for popping open airways to improve oxygenation. It's our go-to for things like obstructive sleep apnea or for patients with fluid-filled lungs from heart failure. But BiPAP is designed to do more. It doesn't just help with oxygen. It actively helps with ventilation, the actual work of breathing, which is why it's so critical for blowing off excess carbon dioxide in something like a COPD flare-up.
Okay, to use these machines safely and effectively, you really have to learn to speak their language. So let's break down the core settings you're going to see and manage at the bedside. Let's start with EPAP, which stands for expiratory positive airway pressure. You're also going to hear this called PEEP. Think of this setting as the foundation of all positive pressure ventilation. It's the baseline pressure that's always there in both CPAP and BiPAP, even after the patient breathes all the way out. So why do we care so much about EPAP? Well, its main job is to keep the alveoli, those tiny little air sacs in the lungs, from collapsing at the end of every breath. Here's a great way to think about it. You know how it's way easier to blow up a balloon that already has a little bit of air in it versus one that's completely flat? That's what EPAP does. By keeping those alveoli splinted open, we improve gas exchange and directly boost the patient's oxygen levels. And now for the setting that really makes BiPAP special, IPAP, or inspiratory positive airway pressure. This is that boost of pressure the machine gives the patient every single time they breathe in. It's what helps them take a bigger, deeper breath with a lot less effort.
See, the whole point of IPAP is to improve ventilation. By giving that higher pressure on the inhale, it helps the patient get a bigger breath. We call that increasing their tidal volume. And bigger breaths mean you can blow off more carbon dioxide. The real magic, though, is in the difference between the IPAP and the EPAP. That gap is called the driving pressure. The bigger that gap, the bigger the breath, and the more CO2 gets cleared out. So if your patient's CO2 is climbing, your first move is probably going to be to increase that IPAP.
So we've covered the what and the how. Now it's time for probably the most important question, who? Deciding which patient is a good candidate for NIV is a huge part of your clinical judgment. So this is our go list. NIV is a true lifesaver for patients in a COPD exacerbation or those with cardiogenic pulmonary edema, and I mean that literally. Studies show NIV actually reduces mortality in these patients. It's also a fantastic tool for patients who are hypoxic from pneumonia or for those with neuromuscular conditions who just don't have the muscle strength to take good, deep breaths on their own. And just as important, if not more so, is our no-go list. These are absolute deal breakers. If a patient is in cardiac arrest, they need a tube, period. If they can't protect their own airway, maybe they're vomiting or they're not fully conscious, NIV is incredibly dangerous because of the aspiration risk. Same thing goes for recent facial trauma, where you can't get a good mask seal, or if the patient is hemodynamically unstable. Patient safety always comes first.
Okay, let's boil all of this down into those high-yield facts, the clinical pearls you absolutely have to know, both for your exams and for safe, smart practice at the bedside. This is the must-know stuff.
If you walk away with only one thing today, let it be this. This little phrase is your key. Is your patient's main problem low oxygen? Think CPAP. Is their main problem high carbon dioxide? Think BiPAP. It's a simple, powerful memory anchor that will help you get the right answer fast. When you have a patient on NIV, your assessments are everything. And the number one most important thing to watch is their mental status. If your patient starts getting more tired, more sleepy, or more confused, that is a massive red flag. It usually means they're retaining CO2 and the NIV is failing. You also need to keep a close eye on their blood gases, check for any skin breakdown from the mask, and listen to their abdomen for gastric distension from swallowing too much air. So here's the bottom line. NIV is a bridge. It's a supportive therapy, not a cure. If you see your patient's work of breathing getting worse, if they look more tired, or if that repeat blood gas comes back and their CO2 is even higher, you have to act immediately. That is a critical finding. It means NIV is failing, and the next step is likely preparing for intubation.
All right, you've got the theory down. Now let's put it all together and see how this plays out in a real-world scenario. This is where your clinical judgment truly shines.
Okay, here's your patient, a 68-year-old guy with a bad COPD flare-up. We've got him on BiPAP with settings of 12/5. His starting CO2 was high at 65, but now, it's 2 hours later, he's getting much sleepier, and his new lab result shows his CO2 has climbed all the way to 78. He is clearly getting worse. So, think about everything we just discussed. You're seeing that declining mental status. You're seeing the lab values going in the wrong direction. You recognize all the signs of NIV failure? What's your immediate priority? What are the first things you do, and who is the first person you call? This right here is what it's all about, taking all that knowledge and making the right call to save your patient.